temporomandibular disorder simplified. So this is a very common disorder, and many times, it is more confusing to treat those disorders. And when I talk about temporomandibular disorder, I mean, it is a separate disease itself. It is not going to cover the neoplasm or pathologies of temporomandibular joint. The word itself says temporomandibular disorders, not you're not going to deal with temporomandibular joint disorders or something like that. So anyway, it is going to include most of the time the joint and the masticatory muscles. So what is temporomandibular disorder? So the term temporomandibular disorder covers a constellation of conditions. It's very difficult to categorize this condition, but many people tried that, but almost everyone have their own shortfalls. Some classify by anatomy, some by etiology, and some by frequency of presentation. We should be aware, however, there is a considerable overlap in any classification system. And because these are often not clinically appropriate. I personally hate classification because, most of the time you will not get a patient based on our classification. The best examples are, trauma. When you study maxillofacial trauma, you will get, Lefort 1, 2, 3. We used to classify like that for the mid-phase fractures. But the presentation from patient side will be combination of all these three, or sometimes isolated, one-sided, and sometimes there won't be the same kind of line we used to study for Lefort fractures. So the classification should be made based on the management. So anyway, we are going to see it later. So the temporomandibular joint disorders affect the articulatory system consisting of, you all know, TMJ, mandibular muscles, and the occlusion. Any factor that has an effect on one part of the system is likely to influence other part of the system. So it is important to avoid tunnel vision when considering possible signs and symptoms of a TMD. Hereafter, I am going to refer temporomandibular disorders as TMD in this whole presentation. So as a dentist in practice, you will inevitably encounter patients with symptoms of a TMD who may present with facial pain, earache, toothache, jaw joints and sounds, or limited movement. So the presentation is so wide, they may come with facial pain, earache, toothache, etc. So they all are broadly classified as temporomandibular disorders. And this is interesting, it is estimated that almost 50 to 70% of the population, overall population, at some stage in their life exhibit some signs of a TMD. This may be subclinical, and the patient might not relate the signs to a jaw problem. Out of this 70%, about 20% they will develop the signs, which implies that the patient will notice that there is hitherto ignored signs. And out of this 20%, 5% of the population will seek treatment. So any disease which has so much prevalence, you think about 50 to 70% is a huge prevalence, So this will happen if the symptoms becomes intrusive in day-to-day life. It is important for you as a dentist to identify these patients and recognize their particular needs and treatment requirements. So this problem is hugely seen by almost all dentists, who are practicing, and students who are studying. TMJ pain is, it's almost ubiquitous. So what it is by definition, the TMD is a collective term for pain and dysfunction of the masticatory muscles and temporomandibular joints. So it is not only TMJ, it involves masticatory muscle dysfunction also. Okay. So I like to, what is the incidence? And it is, 3 to 5 times more frequent in women. That means very frequent in women. And we are going to discuss why it is in the later slides. And TMD has considerable prevalence with significant impact on physical and psychosocial factors. It impacts one's life, social life, as well as physical life very much, this TMD. I like to start with a consensus study report. It was published recently in 2020 by a group of eminent TMJ physicians, they used to call, which includes dentists, oral surgeons, and orofacial pain therapists. They are from the medical fraternity. They all used to treat, and sometimes ENT surgeons also. This is a overlapping area. They all used to treat. And they all come together and form this consensus study report. And what they found in that report is, what are the challenges in care with TMD is lack of coordinated care and abandonment. There is no coordinated care between specialties, So, and many times, we abandon the treatment. We don't know what to do with those patients, who comes regularly with the TMDs. And over treatment and harmful treatment. This is happening, especially mainly done by dentists. They used to think that particular disorder is caused by a lot of other factors. They used to over treat, and which may result in irreversible harmful effects. And it has significant impact on quality of life and financial burden, especially in our country it is not much, but in developed countries they are very much concerned about this as TMDs. They used to spend a lot of money to get rid of this TMD. And it has its own challenges in identifying quality healthcare professionals. Who is the specialist here to treat TMD? Finding them is becoming difficult day by day. And many times people will live with this multiple TMD with multiple comorbidities. They used to think this is a kind of way we have to live with that. So I hope that many people who are practicing, as well as students or interns or postgraduates, must have seen a lot of TMDs. And I myself, used to have this enigma, this dilemma, for years together. What causes this? Whatever we do, it is not going off, etc. But recently, that's why I took this topic. Recently, there are some big advancements and in thinking towards TMD. We're going to see that. So in that report, what they said, they have quoted the patient voices. One patient has said, because of the severity of pain, it is sometimes impossible to eat or talk. The pain from simply smiling can reduce me to tears. Other patient has said, TMD has affected every aspect of my life, physically, emotionally, financially, psychologically, professionally, and it has affected my relationships, my passions, my independence, and at times my dignity. It cut me off at the knees and changed the landscape of my life and what I imagined my life would be. One other patient, quoted that, what I want to see going forward is research on just what TMDs are. Research that validates the safety and effectiveness of every treatment for TMD. This patient has clearly said there is no reason that exists on every other joint in the body. So these are the patient voices towards this disorder. And that consensus report has found a set of findings. One of the findings they found is TMDs are a set of diverse and multifactorial condition. So this is what happened in the recent decades. They found out that it is not from a single etiology, it is a multifactorial etiology. And TMDs are highly prevalent. Okay. And again, they found out that TMDs have a significant public health impact and are a health, social, financial, and emotional burden on many individuals and families. So these are the findings. And so they also found that TMD have been compartmentalized as a dental issue for too long. Okay, for a long time they all thought that it is a dental etiology which causes TMD. And further, they found out that divide between medical and dental care is currently vast and profoundly affects care systems. So they also found that they support a biopsychosocial model of TMD. We are going to discuss about biopsychosocial model a lot in this presentation. Which is an interdisciplinary and can be used across medicine and dentistry to focus on the total person's health and well-being. And they firmly quoted that there are outdated and non-evidence-based beliefs that TMD therapies have been and continue to be harmful. There are a lot of outdated therapies still being followed. And they also found that evidence-based clinical practice for guidelines for TMD are needed, which is not there much in the literature. So these are the findings they found. So based on this canvas, we will go into the topic. And this I like to share here is, there was a study, conducted by indoor people, prevalence of TMD in dental students. So it's intriguing, okay. So the conclusion says that, the study concluded that out of 600 dental students, there are 18.6% people had TMD. So that is a huge prevalence among the dental students. And stress was the highest significant value which can cause the TMD. We are going to discuss about that. So that means, dental students used to have a lot of stress. Okay. TMJ sounds were significantly related to symptoms of TMJ dysfunction, and women showed a higher prevalence. So these are the conclusions of that study. It is just to have how TMD is affecting our profession also. So I'm not going to the details of TMJ for anatomy, but we should know some important things about applied anatomy of TMJ. Okay, we all know it consists of the joint consists of condyle and mandibular fossa, where the condyle articulates, and in between there is an articular disc. Okay, and there are some ligaments. We are going to see what are they. So the bony component is condyle, and condyle has its unique shape. Anteroposteriorly it is flattened, and it articulates with the glenoid fossa, and which is a part of the temporal bone. Okay. So it consists of a joint capsule. Then the whole joint is capsulated. It consists of a joint capsule, and there are few ligaments present there. One of the ligaments are lateral temporomandibular ligament, which is nothing but a thickening of the joint capsule on the lateral side. And this lateral ligament limits the too much lateral portion. The ligaments are there to restrict TMJ movements. It should not go out of control. That's why these ligaments are there. So it limits too much lateral movement. And there are other ligaments like sphenomandibular ligament, which is attached on the mandible and the sphenoidal process. And this limits not too much opening. Okay, stylomandibular ligament is attached to the styloid process and the mandibular in the angle of the mandible. So these ligaments, these sphenomandibular, stylomandibular, these ligaments mostly prevents over opening of your mouth. So coming to there is one more ligament. Its existence is little bit controversial, but the recent studies have said that it is there. They call this as ligament as discomalleolar ligament. It attaches the TMJ capsule to the malleus, that is in the ear, inner ear. The malleus is a bone which is present in the middle ear. Okay, so there is a small triangular shaped ligament which is attached. This ligament is also called as Pinto's ligament, which is actually found out by an author named Pinto. So it's called Pinto's ligament, and the significance of this ligament is, whenever there is overstretching of TMJ, and there may be chance of tinnitus and ear symptoms because of the stretching of this particular ligament, which has not been proven, but the presence of this ligament is nowadays very much proven anatomically through a lot of anatomical studies. So then comes our hero of this whole topic is articular disc. This particular man, you can have a gender, man or woman, it's a complicated structure. And the best way to describe the articular disc is, they used to call this as schoolboy's cap appearance. You can see a schoolboy's cap, The anterior portion of the cap is the anterior extension, and this anterior extension is most of the time is attached to the superior head of lateral pterygoid muscle. Okay, and then it has a middle portion that is intermediate zone, and it has a posterior band which is thick zone, and behind the posterior band there is something called as bilaminar zone. This is a extremely vascular and also extremely sensitive zone. A lot of nerves and vessels will be there in the bilaminar zone. So this is the structure of the articular disc, and you can see the anterior part of the articular disc is attached to the superior head of the lateral pterygoid muscles. So this is about TMJ functional anatomy, and you know muscles of mastication also plays an important role in TMD. You all know the muscles of mastications, and I'm not going to go into the details of the insertion and etc. of muscles of mastications. You know, masseter, medial pterygoid, lateral pterygoid, and temporalis. These are the most important muscles of mastication. So coming to the how TMJ functions, you know, and I like to add here, you know, whenever we study TMJ, we used to think that TMJ is a very unique joint, and they used to call it as ginglimo, arthroidal, a lot of tongue twisters will come, diarthroidal joint, etc. And we are always used to think, no, TMJ is the very unique joint in the body. Absolutely not. If you read about other joints in the body, the most complicated joint is our knee joint, okay, which has too many movements. But TMJ has only two movements. One is hinge, that is rotation. Another one is slide, that is translation. So what happens in the early phase, that is when you open your mouth, initially it will be a rotation. Okay. And then in the later phase, when you cross around 20 mm of your opening, then the condyle translates. That is, it slides and comes in front of it, the eminence. So that is the translation movement. So that's why we get almost 40 mm mouth opening. The first half is going to be rotation, the second half is going to be translation. This is very important because when you come to TMD, we are going to see there are a lot of problems in the phase between rotation and translation. This is the normal functional movement of the condyle, you know, from opening to closing. Okay. Most of the time, the only thing you have to observe here is most of the time you can see the disc is very anterior. It never goes posterior. It never goes posterior. Why it is like that? This articular disc is attached on both sides, anteriorly by the lateral pterygoid muscle, posteriorly by the retrodiscal tissue, that is the bilaminar zone. So this is just a balance between these two structures. They are the one who maintains that articular disc in position. But what happens most of the time? You know, the lateral pterygoid muscle is a powerful jaw opening skeletal muscle, you know. So it has more power than the poor retrodiscal tissue. So that's why most of the time the disc is anteriorly positioned. Okay. So this is the reason in normal anatomy also, normal movement also, the disc is most of the time anteriorly positioned. So these are the anatomy we have seen, that is the functional anatomy. We will go to the historical background of TMD. This is very important because this is like a travel from, you know, inside a tunnel, and almost in this decade after 2010, we almost reached the light at the end of the tunnel. So the tunnel length is almost, you know, 100 years, you know. So we will just go through that journey, you know, what happened with the TMD, the path of TMD pathophysiology, that is, you know, how people understood TMD from the beginning to till now. The first report of TMD was by a British surgeon. You must be knowing that his name is Costin, and you know, so in 1887 they published an article on surgical management itself in TMD. In the decades following this, TMD research focused on single factor explanation of TMD, that is TMJ, muscle or dental occlusion. But they found very little supporting evidence because there are not much research tools now those days. And Costin he is an ENT surgeon. He attributed otologic pain symptoms, any ear symptoms. That is mainly because of the TMJ. They call that as Carsten syndrome itself, which is totally outdated now, because ear symptoms, very rarely mainly caused by TMJ. One reason is mainly because of the Pintos ligament, they used to say, but there is no substantial evidence for that. And still we used to get a lot of patients from ENT surgeons. Whenever patients with ear pain goes there, if there is no ear pathology there, they used to send towards us, that is, it may be because of TMJ. So, but the otologic pain symptom due to this TMJ is outdated. And this is very important because of the many iatrogenic complications associated with TMJ treatment. Based on unfound diagnostic theory, it seemed too many clinical dental researchers and clinicians that the then prevalent practices reflect an unfortunate move. That is, they started experimenting different kind of treatment because there is no strong diagnostic theory. Most of the theories those days are unfounded diagnostic theory. But what happened because of that? They forgot the fundamental dictum in medicine is first do no harm. First do no harm is very, very important. So what happened then? The historical diagnosis become hysterical diagnosis. Then comes the concept of somatization. What is somatization? It's very simple. You might have seen patients, somatization is nothing but manifestation of underlying anxiety neurosis, such as hysteria, in which patients, if you're not able to find out the reason for that particular pain, that is, medically unexplained physical symptoms. But the patient used to say that there is pain. If we are not able to find out, we used to think that there is some problem with this patient. So they are building up a lot of things. But somatization is the scientific concept now. There are science. There is science behind somatization, and this came into existence in the 1950s. So, in this context, difficult to understand symptoms of persistent pain in the absence of verifiable and objective clinical signs came to be thought of psychosomatic, that is, physical symptoms denoting underlying psychopathology. So this is called as somatization. So what is the etiology, real etiology of this TMD? I'm going to go like in three phases, before 2000, from 2000 to 2010, and 2010 onwards. Before 2000, most of the people thought that malocclusion and other related factors were considered fundamental and key causes of TMD, which is absolutely wrong. They really found out people with good occlusion also getting TMD, temporomandibular joint disorder, temporomandibular disorder. And because of that, other way is also true, that people with a lot of malocclusion, they all are not getting TMD. Okay, they are living happily without any signs of TMD. So what happens now? What happened those days? If there is a TMJ pain, they will immediately correct malocclusion through orthodontic treatments, which was valid till 1990s. But after that, they found out that role of malocclusion in TMD is very limited or non-existent, and thus these disorders should not be treated with orthodontics. Then, in the same way, before 2000, they found out occlusion as a causative factor. There are two. Then there are a lot of evidence that occlusion is not a causative factor, and it divided the fraternity into occlusionist and non-occlusionist. And a famous prosthodontist Okesin is an occlusionist who used to substantiate that TMD is caused mainly because of problems with occlusion. But it is also outdated. So what are the causative factors of TMJ? As I said, discussed now, they thought it's an occlusal factor, trauma, emotional stress, and parafunction habits, etc. From 2000 to 2010, the invasive treatments and surgical options for TMD came into use. However, by the lot of treatments like minimally invasive treatments like TMJ arthrosynthesis, arthroscopy, and open TMJ surgeries, discectomies, disc replacement, and sometimes whole joint reconstruction, TM joint reconstruction. All these came into there. It was there before itself, but it has, because of the advancement in surgical aspect, it came into existence very frequently in this 2000 to 2010. However, by the end of this decade, clinical experience and several studies included in systematic reviews reported a lack of evidence supporting the use of arthrosynthesis also or arthroscopy for TMD treatment. But they have a role, but you should not directly jump into such invasive procedures for temporomandibular disorders. From 2000 to 2010, the great controversy came into existence. There were four kinds of approach, that is, four kinds of groups were formed separately. They all started to find their own philosophy against TMD. That is, what causes TMD. One is biophysical approach. The another one is TMD orthopedics. Biophysical approach is, they are almost close to the biopsychosocial approach, but they thought there is no psychological component in TMD. But it is also debated, and it is not being followed nowadays. TMD orthopedics is people who believe in splints, different kinds of splints, anterior biplanes, posterior biplanes, full splints, etc. Those people believed that only this therapy will cure TMD, and it was eventually, there is not much evidence for that. Then came a fascinating philosophy that called airway-centric philosophy. What is airway-centric? I'm not going into detail. That's why I have not prepared a lot of slides on these things, because airway-centric philosophy, they say the posture is an important component, and the centric relation and centric occlusion and the posture, the cervical spine posture and the TMJ posture is very important in TMD. If there is a change in posture, it will result in TMD, so that the posture should be corrected through different kinds of appliances. But it is eventually not accepted by many people, because people used to have, most of the time we don't have, the right side of the face will not be equal to the left side of the face. Some people used to have different postures, but all of them are not getting TMD here. So and again, we are unnecessarily doing harm to the patient by correcting the so-called wrong postures. And so this philosophy is still debated. Then came the neuromuscular dentistry. These people, this group used to think that the TMJ pain is mainly because of masticatory muscles. There is some problem with the muscle, and this muscle is used to pull the TMJ. That's why that TMJ is producing pain. So they used to call that, muscles are the most important thing here. This is also, they used to do electromyographic studies, EMG studies, and then they used to give a lot of appliances to correct muscular spasms, etc. Again, it is invasive, and it may produce permanent damage to the muscle sometimes, through these therapies. So it is not widely accepted. So what is the most accepted one, which is very recently put forth? From 2010, the cognitive and behavioral profiles of patients with TMD have been debated for some years. It was in the present decade that health professionals began to propose behavior-based therapy as a promising treatment. When we were doing post-graduation, in 2000s and all, when the patient comes and says, most of the time they used to say, the pain starts from the head, and now also they used to say, pain starts from the head, concentrates on the TMJ, then it comes down. Sometimes they used to say, the pain goes till the level of the foot. You will get frustrated, because we are not able to find out any evidence on all of these things. Those days, we cannot we cannot diagnose a psychiatric condition also. And we have the dilemma whether to send the patient to a counseling or a psychiatrist. So, but now they found out there are cognitive and behavioral issues in TMJ. So that's what, this paradigm shift has since been changing and developing a wider focus, leaving behind the biomedical structure model. Thanks to advanced neuroscience, biopsychosocial models for diagnostics and treatment that includes physical, psychological, and pharmacological therapies currently have more clinical support and scientific growth. So, what is biopsychosocial model? The most recent research recognizes that TMD is not caused by a single factor, but is a complex disorder with overlapping comorbidities of physical signs and symptoms, as well as changes in behaviors, emotional status, and social interactions as manifestation of general central nervous system dysregulation. So in the end, they found out through neuroscience studies that is, this is a general central nervous system dysregulation orchestrated by both physical signs and symptoms as well as changes in behavior, emotional status, and social interactions also. So these are all may produce TMD. So the model is called as biopsychosocial model. It has 3 Venn diagrams, you can see that. Then it has a biological part, it has a psychological status, that is stress, anxiety, depression, mood swings, etc., and a social framework, relationships with family, friends, work environment. So these 3 together may produce TMD. They are all interlinked. So previously we had the dilemma that whether to treat the patient psychiatrically or whether to treat the patient through counseling. Now it is scientifically proven that through biopsychosocial model that TMD patients, we have to look into the psychological status as well as social frameworks. So we are supposed to treat the patient with the physical signs and symptoms along with psychological status and social framework. Then they found out this biopsychosocial followers, they formed a committee and they sat and written a elaborate research diagnostic criteria for TMD that they used to call it as RDC. What is RDC? This is a recognized classification by the international scientific community for diagnosis, evaluation, and categorization of TMD to date. So their importance is highlighted by the fact that it has been translated into more than 40 languages, not in Indian languages, but in a lot of other languages it's been translated. What has been translated? That questionnaire. So what they did, they divided this TMD criteria into 2 axes. One is axis 1 and another is axis 2. Axis 1 is physical pain and symptoms, that is, myofascial disorder, disc subluxation or arthritis or arthrosis, etc. Axis 2 is totally psychological and behavioral profiles. So what they are advising is you have to treat the patient based on both the axes. Through axis 1 you can treat through pharmacological, surgical, occlusal, etc. But you have to address the axis 2 also, that is through cognitive behavioral therapy like self-monitor, self-care, stress reduction, etc. When you put forth these 2, you will get a real relief for those patients. Because most of the time TMD patients used to come regularly to us that you gave a medicine, it was good for some time, after a week or something like that, after a month or something like that, they used to get that particular problem again and again. But if you treat the axis 1 along with axis 2, this is considerably reduced. How to do that, we are going to see it. So this is just a rough picture of the questionnaire developed by the research, that is RDC questionnaire. Myalgia, what are the things to record when a patient comes? It's an elaborate questionnaire, but it really spot on. It really finds both the axes very easily. So this is they have included headache attributed to TMD also. And the most important thing they found out, the recent literature found out is this one. 85% 85 to 90% with TMD improves without treatment. Okay. I have highlighted that particular sentence given by an author. The first was that 85% to 90% of people suffering with TMD pain got better if you did nothing at all. Spontaneous recovery, they called it, that this is called spontaneous recovery, and there are dozens of studies that document those statistics. When we combined the recommendation of to use only reversible treatments, reversible treatments, and the basic tenets of all treatment is, as we discussed before, do no harm. So 85 to 90% of TMD improves without treatment. So what is this central nervous system deregulation? How it happens? Then came the neuroscience. They found out recently the neurophysiology of trigeminal sensory system. They found out some peculiarity in trigeminal sensory system. When I say trigeminal sensory system, nothing but trigeminal nerve and its branches, how it conducts the particular senses. So there are actions, sensitive actions of the trigeminal nerve innervates the majority of cranial and facial tissues. We all know that. Except the posterior area of the cranium, the mandibular angle, part of the external auditory canal and pavilion, and part of the pharynx. Apart from, other than these structures, it is all been supplied by trigeminal nerve through the divisions. Although the primary innervation patterns and the nerve signals are similar throughout the body, the craniofacial region has some particularities. What are the particularities here? One difference is, the relationship between A fiber and C fiber, that is myelinated and unmyelinated afferent fibers, is closer in trigeminal nerve than in the spinal nerve. So that's why, this situation could generate a higher mean velocity of conduction in trigeminal area. That means, what is the clinical interpretation? The pain will be much faster and it persists in that region for more time. And also, the trigeminal region, they have very few efferent sympathetic axons. And these are all Greek and Latin for me also. But what is the clinical interpretation? So some authors have postulated that this peculiarity could have relative influence on painful states maintained by the sympathetic nervous system in the trigeminal region. That is, that is a painful, dull, aching pain located. We are not able to locate most of the time in the people used to say, no, I have pain on one side of the face. They may not locate that particular pain. That may be attributed to this fewer efferent sympathetic axons and trigeminal nerve. So this is about the recent developments of neurophysiology of trigeminal sensory system. So what is this? What are the symptoms of TMD? TMD, the main symptoms are pain, limited range of motions, and TMJ sounds. Pain is the important symptom. Limited range of motion means it is restricted mouth opening and sounds, clicking, crepitus, etc. So the pain is aggravated by provocations such as chewing, yawning, or talking. The pain can be intermittent or persistent, and it may be of moderate intensity on average, but there are cases with severe pain intensity also. Pain and tenderness upon palpation of pericranial muscles, that is, temporalis, masseter, etc. And TMJ are most common clinical signs, and most of the time they coexist. Patients used to have pain in both the region, both TMJ and masticatory muscles. This is the questionnaire developed by the same RDC, the Research Diagnostic Criteria Committee, and it's again an elaborate pain questionnaire. Like, if you have a headache, if the last 30 days, no, yes, kindly grade it from 1 to 5, etc. So this is the questionnaire. It is very much available in internet, and you can go through this questionnaire, which is very elaborate. And if you have time, it's better to use this questionnaire for your patients. So then comes the examination. How to examine a temporomandibular disorder, that is, in patients with temporomandibular disorder. First one, you have to see the mouth opening. Many times it will be, mouth opening is like, most of the time it will tell you more the diagnosis. Sometimes there will be a deviation of mouth opening. Sometimes there will be a click while opening the mouth. Many times there will be restricted mouth opening. So mouth opening assessment has to be done as a first kind of examination. You have to measure the lateral jaw movements also. Is there a, whenever they open, if they go on one side and coming back, etc., you have to measure the lateral jaw movements. Then lateral palpation of temporomandibular joint. You have to keep your finger on the temporomandibular joint, ask the patient to open and close the mouth, and ask the patient whether there is pain on opening or closing, or both during opening or closing. You have to ask. And most importantly, you have to do intra-auricular palpation. This is what we most of the time miss, because as I said during the anatomical part, the posterior to the disc, there is something called as bilaminar zone, which consists of a lot of blood vessels and nerves, which is extremely sensitive. So whenever there is some problem in that region, the inflammation occurs only in the posterior bilaminar zone. That means the pain will be more in that posterior region. So the posterior region can be accessed only through intra-auricular palpation. You have to insert your little finger inside the ear, and you can feel the posterior head of the condyle, and you can definitely feel the pain. So intra-auricular palpation is very important. Then you have to palpate all the three muscles mainly. One is masseter. You have to palpate the masseter. Temporalis in the temporal region. And lateral pterygoid, you cannot palpate directly, but the function of lateral pterygoid, you can see whether there is pain in lateral pterygoid by asking the patient to open the mouth while you are resisting it from the chin region. That activates lateral pterygoid. If there is a lateral pterygoid spasm, it gives a very sharp pain. Then you have to look for clicking and crepitus. Okay, what is the difference between clicking and crepitus? We will come to it later. But most of the time, there will be a loud click. We used to hear. Patient used to say, "No, I'm hearing my click." Click. But the ideal way of listening to the clicking or crepitus is through a stethoscope. You can keep the stethoscope and you can hear the sound. While whether it is clicking in the opening, that we used to call it as opening click or closing click. Okay, you can very well hear it through a stethoscope. So this is the way you should examine the patients who comes with TMD, that is pain in that region. Then we will see some of the factors which may be responsible for TMD. Is there a genetic predisposition? Is it hereditary? There is a very landmark study called OPRA study. OPRA, that is an abbreviation for Orofacial Pain Prospective Evaluation and Risk Assessment Study. The study indicated that there are 2 genes associated with TMD. It is still at the rudimentary level. Maybe in the coming decades, we may come with a lot of information about these genes. HTR2A and COMT. They found out these two genes are more prominently seen in TMD patients. Is there an hormonal influence? Since TMD is more frequently in females, some have suggested that female sex hormones such as estrogen are involved in pain modulation. That is, estrogen seems to be involved in modulating TMJ inflammation and regulating nociceptive responses in both peripheral and central nervous system. So, is there a level of estrogen which causes this TMD pain? When you can expect the level of estrogen increases? Level of estrogen increases routinely just before ovulation. Okay, that is the luteal phase. Okay, so that just before the periods. So when the patient comes to you that I am getting this kind of an pain during this time, you may think it may be because of an estrogen, that is hormonal influence. And I have seen many pregnant patients used to have TMDs, but because the estrogen level will be exponentially increased during pregnancy, you all know. So especially in 3rd trimester, I have seen many patients in 3rd trimester used to have TMD problems, which actually goes by itself when after the pregnancy, once the estrogen level comes down, it will come down. The TMD also will come down. So you can, if the pain is persistent, you can discuss with the gynecologist to modify the level of estrogen if in need, if that is persistently occurring every month or during pregnancy. You can have a consultation, you can have a discussion with your patient's gynecologist. So is there a pain comorbidity? Yes, many TMD pains are associated with headache, neck pain, and back pain. And almost it is, TMD pain is almost 8 or 9 times is more likely to have headache. What is the difference between headache and TMD pain? Again, with that questionnaire, we can easily find out. And headache is many times it's like unilateral only. Sometimes it is bilateral, but TMD pains mostly it is unilateral in nature. But in unilateral headache and unilateral TMD pain, how to differentiate? Most of the time, the headache will be in the frontal region, forehead region, whereas TMD pain will be mostly on the lateral region, that is the TMJ area region. And headache pain, like migraine, etc., used to have the symptoms like watering of the eyes, nausea, vomiting. Those symptoms used to be there, but in TMD, you rarely get all those symptoms. So almost patients have almost 9 times more likely to have headache compared to individuals without TMD pain. So there is pain comorbidity. Obviously, you all know trauma and parafunctions cause TMD pain. Trauma we can classify as macro and micro trauma. Macro trauma, it occurs following injuries or after prolonged mouth opening, such as during dental treatment, prolonged dental treatment, or during endotracheal intubations. When they use their laryngoscope to open the mouth widely during general anesthesia, there may be trauma to the temporomandibular joint. We used to call it as traumatic arthritis. That is also part of TMD. Microtrauma, it's mainly occurs due to parafunctional habits, mostly by bruxism or bracing the jaw or tongue thrustings, fingernail biting, or pencil or pen chewing. These are all parafunctional habits. So the habits will cause microtrauma to the TMJ. Is there an occlusal factor? We discussed it. The relationship between dental occlusion and TMD has been a controversial topic in the dental community, and studies have said that many studies are very few and inconsistent studies support occlusal factors. So no support for the belief that orthodontic treatment may cause TMD. So orthodontic treatment also, if the ortho patients used to have TMD, it is not because of the TMD, the ortho treatment they are having pain. It is mainly because of the anxiety, the psychological factors in patients with under orthodontic treatment. I have seen many patients, they are more anxious. They know how the teeth are going to move, whether it's going to be beautiful or not. They used to have the stress. Because of that stress, they used to develop TMD, not because of the orthodontic treatment. As we discussed, psychosocial factors. Individuals with TMD-related pain show higher levels of stress, anxiety, depression, somatic awareness, pain catastrophizing, and kinesiophobia compared with controls. This has been established. Many times, young females used to have this kind of a pain. We immediately used to ask 2 things. One is, is it whether you are having exam on these dates or not? Because examinations leads to anxiety, stress, etc. Or it may be depression related. Okay, so many times the level of stress is directly proportional to the level of TMD. So stress reduction, that's why biopsychosocial model is being followed. You have to address the psychosocial issues also. So psychological abnormalities. Is there psychological abnormalities like psychiatric diseases have any relation with TMD? Yes. It is bidirectional in nature. That means sometimes depression may aggravate an existing sensitization, which may produce TMD. Sometimes TMD themselves will, consistent pain and not being treated properly, patient may go for depression because of TMD. So it's bidirectional relationship between depression and TMD has been established. So we have to again address both the things. Is there sleep associated disturbance which causes TMD? One German study said, facial pain in the morning occurred in 71 patients with TMD compared to 13.6% in healthy controls. That is, Deteriorating sleep quality predicted TMD incidence. The Oprah study, the genetic study also said that if your patient have some kind of sleep disturbance, it used to reflect as TMD. It may cause TMD. So in your history, you have to ask whether the patient is having a sleep disturbance or not. If they have sleep disturbance, you have to pharmacologically treat them for sleep, or you have to find out the cause for sleep disturbances. So this is an interesting study. In this study they found out violinists used to have a lot of TMDs. There is something called as music performance anxiety, MPA they used to call. These music performers, they did a study. They found out that violin players had a high prevalence of reported TMD symptoms because because violin is a very difficult instrument. The stress level will be more when they do than other instruments. So the music performance anxiety is very common in violinists, and they found out they also had significant amount of TMD in them. That is, they also had TMD. So all these things, it's directing towards a psychosocial element in TMD, whereas we normally treat them through physical signs and symptoms. I just want to emphasize the whole presentation mainly for that. Okay, you have to treat them as a patient, you have to treat them psychologically as well as socially, and also you have to treat your normal physically also, like through different mode of treatments. So what is the treatment for TMD? Now we know these are things which are causing the TMD. What are the treatments available? The treatment need for TMD, the general adult population, is substantial, and it varies according to definition, criteria, and age. So you have to treat the patient may be on high psychological distress or high state of pain amplification, which may lead to painful TMD. These are all maybe the reasons behind that. Okay, mood, anxiety, depression, stress response, somatization, neuroendocrine function, autonomic functions, pro-inflammatory states. These are all maybe the causes of TMD. There are environmental contributions like physically trauma, infections, social environment like life stresses, cultural and health beliefs, and they all are environmental contributions. So all these things may cause TMD. How to treat them? Behavioral therapies. Reports show that behavioral therapies are very effective in treating TMD. That means we are not going to do a behavioral therapies. You have to send the patient to these therapists. They include counseling, education, that CBT, that cognitive behavioral therapy. It's very, very common in children. So you have to send the patient to those therapists for few sessions along with your own therapy. The results will be very good. So the Swedish national guidance suggests their use as a first-line therapy for TMD. So they are treating TMD first with behavioral therapies, not with drugs or something like that, not with your occlusal splints, etc. They treat them with behavioral therapy as a first line of therapy in Sweden. We all know oral pharmacotherapy, that is nothing but used to give pain medications, which is very much included in the literature. You have to give pain medication. Normally we used to give NSAIDs, and sometimes we used to give corticosteroids and other things like muscle relaxants, anxiolytics, opiates, TCAs, lidocaine patches. These are all pharmacotherapy. Okay, so you see they have included antidepressants also, that is TCAs here, as a one of the line for managing TMD. And this is a simple thing. I think this gives a lot of relief most of the time for temporomandibular disorder pain. We used to give oral pharmacotherapy, but the research has significantly said that topical pharmacotherapy is much effective than oral pharmacotherapy. That is, instead of giving painkillers or along with painkillers, that is, you can give a topical pharmaca, that is painkiller, that is like diclofenac, over on gel or over on sprays. So they found out scientifically also that is it inhibits the prostaglandins and NMDA subtypes, etc. So this you can very well prescribe to any patient with TMJ pain. There is one problem with that is consistent applying, that is self-medication. If the patient does this again and again by their own in their own way without consulting you for a long time, because it is phased, the facial tanning may occur in those regions because of that the topical agents. So you instruct the patient that use it judiciously, otherwise there is the skin will go for tanning, and which gives a ugly look for those patients. So this you instruct them, but this is very, very effective instead of oral pharmacotherapy. Muscle relaxants, definitely muscle relaxants in dentistry as a role means that is mainly in TMDs, especially when there is a masticatory muscle dysfunction, that is the muscle related problems. Diazepam is very commonly used. It covers both the things, both muscle relaxant as well as it's a kind of an anxiolytic agent. So it works very well with TMD pain. So you can very well subscribe diazepam. Only thing was you should know the dosage, and you should tell the patient not to abuse it. You have to restrict the dosage to a certain level, and they should not drive, etc. You have to tell them. And cyclobenzaprine is nowadays they found out this is one of the muscle relaxant, has a very positive effect on TMD, and that sedative effect is also low. You can try cyclobenzaprine also. And TCS, this has become recently, in my prescription, many times if I found the patient has a stress-related problem or anxiety-related issues, I prescribe TCA. This is one of the changes I have done in my recent practice. That is, TCA sometimes does wonders for TMD pain. So along with your painkillers, you can give TCA. What common TCA use? Amitriptyline you can use, or not triptyline. You can give low doses, that is 10 to 35 milligram per day in divided doses or in one single dose also. If it is not responding, you can go for gabapentin for non-responders. These are all very safe drugs. You can give it for sometimes, which gives a huge relief. I started seeing patients, TMD patients used to come regularly to me. It was sometimes, they will come in every 2 months, 3 months, etc. But after TCA prescription, that frequency has reduced. So you can very well add a TCA in your prescription for TMD. This is injected pharmacotherapy, which is mainly done by oral surgeons or sometimes with oral medicine specialty people. Then, but it should be reserved in the end, as I said, 85 to 90% TMDs can be, it is spontaneous recovery will occur. And if it is not occurring, your pharmacotherapy, that is conservative management, will take care. Very rarely you need this injected pharmacotherapy. Injected pharmacotherapy, that is corticosteroids, we used to inject methylprednisolone or dopamedrone. In intra-joint injection can be given for severe pains, but it should be reserved when your conservative treatment fails. Surgical interventions, actually there is no, the open surgery is contraindicated in TMDs most of the time. Only if there is a severe osteoarthritis where the joint is totally gone, you can go for joint replacement. But other than that, discectomy, and sometimes they transfer disc from some other parts. Those are all obsolete now. If anybody does that, it is really harmful to those patients, because TMD is not a disorder which requires surgery most of the time. So medical management or rehabilitation is recommended over other surgical options. Dental management, what normally we used to do, orthopedic stabilization therapy, that is splints. Commonly used splint is anterior biplanes, misused most of the time. And occlusal therapy in the mean of orthodontics, etc. And again, I'm saying TMD, the role of occlusion in TMD is been very minimal and has been published in different meta-analysis and systemic reviews. So, so when a prosthodontist treat a TMD, most of the time they will go for occlusal splints. But the literature says otherwise. You have to address the psychosocial issues. Most of the time, the patient will. What is the problem with this splints? I've seen many patients wearing anterior bite planes for TMD. It's very easy to construct immediately. Dentist will take an impression, produce give an anterior bite plane. Definitely, it gives a lot of relief. Because what it does, it brings the mandible forwards. That means the mandible is away from the articular disc. That means there is no compression there. Immediately patient feels, okay, my pain has gone. Thank you, doctor, they will go. But how long they can wear the splint? Once if they discontinue the splint, what happens? You may produce a irreversible damage, disturbed occlusion. I have seen personally these kind of occlusions because anterior patients, many patients used to have, when they have TMD pain, when they get this relief, they will wear this particular bite plane for years together, resulting in total malocclusion. So anterior bite plane role in TMD is almost nil. Please don't use it. There is something called as therapeutic jaw exercises, stretching, passive stretching. Again, what they say, the passive stretching improves muscle mobility and range of movement of the TMD. And this is as I said, this is one of the postural philosophy. That is, if you do a passive stretching and all, it comes to the natural posture that will improve the TMD. It is like, it is not recommended because it is time consuming, and the reports have clearly said it has not much positive effect on TMD. So therapeutic jaw exercises is a questionable treatment for TMDs. This is being done many times, especially by the oropain therapist. They used to have all these TENS and radiofrequency energy, all these machines they used to have in their clinic. Not dentists, oropain therapists. They are pain therapists from the medical fraternity. But these TENS and everything, ultrasounds, physiotherapies, they have very little effect in the management of TMD. These things are not my words. They are all very much established in literature. So there are modified diets they used to give for TMD patients. We normally, what we do is we ask the patient to give rest to the temporomandibular joint by taking soft diet. But what happens, actually it gives